Welcome to this explainer. If you're a focused learner who really wants to understand the nuts and bolts of the human body, you are absolutely in the right place. Today, we're bringing high energy to a fascinating journey. We're going to go all the way from the microscopic anatomy of a single cell right up to the systemic diseases that can literally alter your entire life. We're talking about the thyroid gland. It's this vital little organ that essentially dictates the rhythm of your entire body.
Okay, so let's just dive right into this. 20 to 25 grams. That is an absolutely wild number when you really stop and think about it. I mean, a normal, healthy adult thyroid gland weighs less than an ounce. But, you really can't let that incredibly tiny weight fool you. This little structure is the body's ultimate metabolic engine. It dictates how fast your heart beats, how quickly you digest your food, even how you regulate your body temperature. Literally every single system in your body relies on the output of this 20-gram powerhouse just to function properly.
Now, to appreciate where we are today in medicine, we kind of have to look back. Goitres, which are these massive enlargements of the thyroid, have actually been documented all the way back to 2700 BC. And get this, back then, one of the most effective treatments they had was feeding patients burnt seaweed, which, well, we now know worked because seaweed is packed with iodine. But the gland didn't actually get its official name until 1656, when an anatomist named Thomas Wharton called it the thyroid. It comes from the Greek word thyroides, which means shield-shaped. And as we'll see, it sits right at the front of your neck like a tiny biological shield. So here is our clinical roadmap for today. We've got number 1, the shield in your neck. 2, anatomy and development. 3, the chemical hormone factory. 4, hyperthyroidism, system in overdrive. And 5, hypothyroidism, the engine stalls. All right, moving right along to section 2, anatomy and development. You know what's crazy? The thyroid's journey begins incredibly early. We're talking around the 3rd week of gestation in utero. And surprisingly, it doesn't even start down in the lower neck. It actually originates way up at the base of the developing tongue, at a spot called the foramen cecum. From there, it physically drops down the throat as the fetus grows. It travels down this epithelial-lined tube called the thyroglossal duct, and eventually it just settles into its final position right there anterior to your windpipe. Now, what's really fascinating here is exactly where this gland ends up setting up shop and what surrounds it. The thyroid has 2 lobes connected by a little bridge of tissue called the isthmus, and it wraps just below the cricoid cartilage of your larynx. And right next to it is this incredibly complex network of cervical lymph nodes. The thyroid has a remarkably rich blood supply and really extensive lymphatic drainage, actually passing lymph directly into the deep cervical and mediastinal nodes. But here is where the anatomy gets super high stakes. Tucked right behind the blood vessels in this area is a small, vital structure called the recurrent laryngeal nerve. It runs straight behind the thyroid and directly into the voice box. So surgeons have to be incredibly precise here. They have to carefully dissect the fascia just to avoid this nerve. Because if it gets injured or accidentally cut during a thyroid removal, the patient loses the ability to tense their vocal cords. No way around it. That means they might never hit high notes again, they can't project their voice, and they'll suffer from really severe voice fatigue. It's a huge deal. Let's dive into section 3, the chemical hormone factory. Okay, so now that we've covered the macrosurgical anatomy, let's completely shift our perspective. When we zoom all the way down to the microscopic cellular level, the main functioning unit of the gland is the lobule. And each lobule consists of 24 to 40 of these spherical structures called follicles. Think of them like tiny biological vats. They're lined with cuboidal epithelial cells, and right in the middle is the central colloid. This is basically a storage warehouse where a large protein called thyroglobulin just sits, waiting to be turned into active thyroid hormone. So, how does the magic happen? Making those hormones happens in 4 distinct, highly regulated steps. First, the gland literally traps inorganic iodide straight from your bloodstream. Second, an enzyme oxidizes that iodide into active iodine. Third, that iodine binds to tyrosine residues on that thyroglobulin protein we were just talking about. And finally, fourth, they couple together to form the actual hormones, T3 and T4. Going back to our engine analogy, think of T3 as the fast-acting, high-octane gas. It gets to work within hours. T4, on the other hand, is more of a slower-acting reserve, and the foot pressing down on the gas pedal, that's TSH, or thyroid-stimulating hormone, coming all the way from your pituitary gland up in the brain. Which brings us to section 4, hyperthyroidism, or the system in overdrive. So what actually happens when this well-oiled factory goes totally rogue?
Well, the absolutely crucial point here is understanding the negative feedback loop that controls this whole shebang. When a doctor runs a thyroid panel, a normal or euthyroid patient is going to have normal TSH and normal T3 and T4. Pretty simple. But consider the thyrotoxic or hyperthyroid profile. Here, the T3 and T4 levels are through the roof. Because there is just so much hormone flooding the blood, the brain senses it and completely shuts off its signal. It basically takes its foot entirely off the gas pedal. And that is exactly why the TSH drops so low that it becomes absolutely undetectable.
Now, the most common cause of this overdrive in North America is Graves' disease. This is a truly fascinating yet pretty destructive autoimmune condition. Instead of relying on the brain's TSH to tell the gland to get to work, the patient's own immune system starts producing these rogue antibodies. And these antibodies, they actually mimic TSH. They bind right to the receptors on the thyroid and basically lock them in the on position. This causes the entire functioning tissue of the gland to become hyperactive, leading to a massive overproduction of hormones and a diffusely enlarged neck known as a goitre. And unfortunately, it most frequently occurs in younger women.
And the physical toll of this autoimmune disorder? It's really stark because it doesn't just stay in the neck. The antibodies actually target tissues across the body that share similar proteins to the thyroid. So you see these severe extrathyroidal manifestations. We're talking about Graves' ophthalmopathy, where immune cells infiltrate the muscles and fat behind the eyes, literally causing them to bulge forward. It can also show up as pretibial myxedema, which is this thick, swollen dermopathy on the lower legs. Make no mistake, this is a severe, system-wide inflammatory crisis.
And finally, Section 5, hypothyroidism, where the engine stalls.
Let's flip the script and transition to the exact opposite extreme of the clinical spectrum. It is a completely reversed picture. With hyperthyroidism, remember, the engine is revving way too fast. Patients are suffering from diarrhea, heat intolerance, rapid weight loss, and a racing heart. But when the engine stalls out in hypothyroidism, everything just slows down to a crawl. GI motility drops, causing severe constipation. The body simply can't generate enough metabolic heat, which leads to this extreme cold intolerance. Patients experience sudden, unexplained weight gain, their speech might actually slow down, and they suffer from a crushing, severe fatigue.
So why does the engine stall out in the first place? Well, if a patient previously had their thyroid surgically removed, or maybe treated with radioactive iodine for Graves' disease, they're naturally going to lack those hormones. But on a global scale, dietary iodine deficiency is a massive, massive cause. Remember those 4 steps of hormone synthesis we talked about? Without iodine, you simply cannot build T3 or T4. It's impossible. This leads to endemic goitres in many parts of the world, though it's relatively rare in places with iodized salt. But in areas where iodine intake is sufficient, the leading culprit is overwhelmingly Hashimoto's thyroiditis. Hashimoto's is another autoimmune disorder, but instead of stimulating the gland like Graves' does, the immune system actually destroys it. Specific immune cells called cytotoxic T cells infiltrate the gland. They team up with autoantibodies to attack and kill off those tiny microscopic follicles we looked at earlier. So the normal, healthy thyroid tissue is slowly replaced by completely useless fibrous and lymphoid tissue. Clinically, a doctor will often feel this as a firm, lumpy, or buccellated goiter in the neck. And as that functional tissue dies off day by day, the patient just slips deeper and deeper into hypothyroidism. So, we've seen how this tiny 20-gram organ acts as the master metabolic shield of your entire body, right? And we've seen exactly how delicately balanced its chemical factory truly is. But as we look at the rising prevalence of conditions like Graves' and Hashimoto's around the world, I really want to leave you with this provocative thought. With autoimmune disorders generally on the rise, how might our modern environments, our diets, and our everyday stressors be pushing this ancient 20-gram shield to its absolute biological limits? It is a huge question, and it's one that researchers are desperately trying to answer right now. Thanks so much for joining me on this deep dive into the thyroid, and hey, keep learning.